of breast has a huge psychological impact. It not only enhances self-esteem, body image, positivity, impact on social and sexual life. There are now adequate studies to show that this has an impact even on the overall survival rates of the patients. Breast aesthetics means planning a surgical procedure to improve the appearance and retain and enhance the characteristics of the normal breast. And currently, it should be considered as an integral part of the breast cancer treatment. Now, the aesthetics in breast cancer surgery are, as I said, preservation of breast with oncological safety. Like, as you're all aware, like the primary aim is to have a surgery which gives a resection-free margin. So that is the prime goal even in breast conserving surgery. And it has been shown in many studies, especially a study way back in 1990s by Fisher Group, which showed that the survival rates after breast conservation surgery are as good as that of the mastectomy. Thus, breast conservation surgery is oncologically safe. Later on, after reconstruction has been used for following mastectomy, there are also studies which have shown that following mastectomy with reconstruction has long-term equivalence with breast conservation surgery as well as conventional mastectomy. Now, when you look at the aesthetic breast cancer surgery, you can classify them broadly into two categories. One is the breast conservation surgery and the oncoplasty. And second is total breast reconstruction following mastectomy. The other procedures which can be considered as aesthetic breast surgery are reduction mammoplasties, mastopexy with breast augmentation, nipple areolar reconstruction, and use of free fat transfer. Now, when you look at the breast conservation surgery rates at the post-mastectomy rate in the Indian scenario, as you compare it to the West, as you compare it to the West, the breast conservation rates in the West are to the tune of 58 to 63%. As compared to it in India, it is about 5.6%. Though it varies between 11 and 46, the average rate is about 5.6%. But when you look at the post-mastectomy breast reconstruction rates, these are quite dismal, which is less than 1% as compared to 40% elsewhere. Now, these are the breast conservation surgery rates in different countries. As you can see, in India, it is about 5.6%. Now, the goals of aesthetic breast cancer surgery, as I have said, let me re-emphasize again, it is preservation of breast with oncological safety. And this can be achieved either by breast conservation surgery or oncoplasty with flap reconstruction. This could be mastectomy plus reconstruction with or without, with autologous tissues or the implants. However, there can be need for contralateral breast surgery in the form of symmetrization if the breast which you have reconstructed is different from that of the contralateral breast. The term oncoplastic breast surgery is derived from the Greek word onco means tumor and plastic means to mold, and it merges a tumor-free resection with soft tissue rearrangements in the form of plastic surgery, thus favoring a good cosmetic outcome. American Society of Breast Surgeons defines breast oncoplasty as something in which you incorporate oncological partial mastectomy with ipsilateral defect repair using volume displacement, which is that you try to rearrange the breast tissues, or a volume replacement technique. And in some cases, you may have to do a contralateral symmetrization. Now, this is the classification of the different oncoplastic techniques. They are broadly classified into volume displacement technique and the volume replacement. In the volume displacement, it could be either a level 1 oncoplasty where less than 20% of the breast tissue has been removed. Here you can achieve a good cosmesis by just a tissue rearrangement. Level 2 is where about 20 to 50% of the breast tissue is removed, wherein either you have to do a contralateral symmetrization or you have to do some sort of circumvertical mastopexy in the same breast. And wherever you remove more than 50% of the breast, you need to do a volume replacement. So now I request Lakshmi to tell us more about techniques of oncoplastic breast surgery.
Thank you, sir. Now we'll discuss about the techniques of oncoplastic breast surgery. So, as sir said, level 1 oncoplasty contains both volume displacement and contains volume displacement methods. So here less than 20% of the tissue is excised, and you have approximation of the medial and lateral pillars and local tissue rearrangements. So there are many techniques by which level 1 oncoplasty can be done by volume displacement methods. So let us see a few of them. So this is Grissotti flap. It is done for central quadrant tumors, like we have tumors beneath the nipple. So we excise the nipple and areola and rotate a flap to fill in the defect. So these are some pictures of our patients who underwent breast conservation surgery with Grissotti flap reconstruction. Now coming to round block technique. So these are used for small tumors that are present around the nipple and areola. So in which a circular donut of tissue is deepithelialized and primary closure is done with approximation of pillars. This shows a picture of our patient who underwent round block technique. I'll describe the technique with the help of a video. So as you can see, a circular marking of the nipple areola is done, and at 1 centimeter circumferential marking is done, and this is the portion of the donut that is deepithelialized, so as to ensure access to the tumor. So you can see the all of the donut is deepithelialized. Now thin skin flaps are raised so as to approach the tumor. This is done at the location of the tumor. So you can see that the flaps are raised, and you go beyond the tumor and then deep into the pectoral fascia. Then all around the tumor, ensuring an adequate margin of 1 centimeter, the tumor is excised. So here you can see that the tumor is excised. That is the defect. Then you have approximation of the pillars, medial and lateral pillars, using oncoplastic techniques. You can see the pillars are being approximated. And finally, the subcutaneous tissue is approximated with the areola. And this is the post-operative picture. You have bursting sutures along the nipple. So other techniques for oncoplasty include, again for small tumors around the nipple areola, you can use the battering technique, hemi-battering technique, or the crescentic technique. Now coming to level oncoplasty, in level oncoplasty you have both volume displacement as well as volume replacement techniques. First we come to the volume displacement techniques, in which around 20 to 50% of the breast tissue is excised. So this includes reduction mammoplasty, which can be done for larger tumors and larger breasts, in which more than 20% breast tissue is excised. Can be done by the superior pedicle and the inferior pedicle base flap. So this is one patient who underwent bilateral reduction mammoplasty. This is the final outcome. More than 1.3 kg tissue was excised from either breast. Now coming to level 2 oncoplasty, the volume replacement techniques, in which more than 50% of the tissue is excised. Here you have a variety of techniques, including perforator flaps, myocutaneous flaps, free flaps, lipomodeling, and implants. I'll be dealing with perforator flaps. So perforator flaps are flaps that include the skin and subcutaneous tissue, avoiding the muscle, thereby decreasing the donor site morbidity. So these flaps may be used based on the intercostal arteries or based on the internal mammary arteries. So intercostal arteries, you have the anterior intercostal artery perforator flap and the lateral intercostal artery perforator flap. Then you have the internal mammary artery perforator flap, and you have two arteries coming from the axillary artery, the lateral thoracic artery perforator flap and the thoracodorsal artery perforator flap. So these are few pictures of our patients who underwent lateral intercostal artery perforator flap. So you can see the tissue lateral to the breast is removed, is based on a pedicle, is rotated to fill in a defect in the breast. So it has minimal donor site morbidity and has a very good cosmetic outcome. So these are other pictures of patients who underwent lateral intercostal artery perforator flap. Now coming to thoracodorsal artery perforator flap, here skin island over the LD muscle, latissimus dorsi muscle, is taken and rotated to fill in a defect. Here also no muscle is taken, it is a perforator flap and has a good cosmetic outcome. Now the difference between LICAP flap and the TDAP flap is that in a thoracodorsal artery perforator flap, you have a longer pedicle which can be easily rotated to fill a distant defect in the breast and also larger volumes. Now coming to anterior intercostal artery perforator flap, as you can see here, this is the perforator that is based on the anterior intercostal artery perforator flap. This is well suited to replace defects in the lower quadrant of the breast. These are few pictures of patients who underwent anterior intercostal artery flap. The whole flap is based on anterior intercostal artery and the portion of skin is deepithelialized, and this flap is tunneled and rotated to fill in a defect in the medial quadrant. Internal mammary artery perforator flap has advantage of the perforator being more medial, so that a longer pedicle can be rotated to fill in a defect, especially in the upper inner quadrant, which is the most difficult quadrant for breast reconstruction. So these are few pictures of patients who underwent an internal mammary artery perforator flap. You can see the perforator is more medially located. Now coming to myocutaneous flaps, I invite Dr. Santosha to discuss it.
Thank you, Lakshmi. So we'll be discussing the lattice torsion flap as a volume replacement technique. That is a myocutaneous flap. It is robust. It is a robust flap with reliable blood supply from the thoracodorsal artery and the lumbar arteries also. So it has tissue similar to breast parenchyma. So it improves aesthetics in breast reconstruction. It is a simpler technique for surgeons to adopt, and it is considered workhorse flap in breast reconstruction. So indications when we are resecting more than 50% of breast volume and tumors in the medial and inferior medial quadrant of breast. This is the most unforgiving location to go for research in breast cancer. So and also post mastectomy reconstruction, it can be also used in combination with implants. So we'll discuss the surgical technique in one of our cases. This is 45 years female who came with status post lumpectomy outside, and we can see the scar is very close to NSC, and we for breast conservation we'll have to resect more than 50% of the breast volume. So we plan a breast conservation surgery with a LD flap. We mark the tumor with the resection margin. You can see the margin, and mark the skin island for the flap harvesting and the outline of the LD muscle with iliac crest and the scapular tip of scapula. Then here we raise the flap with the skin island, and we insert the flap into the defect. We routinely perform and assess the vascularity of the flap routinely with the spike cam and the injection of ICG. And this is the image post-op 2. So these are some of our patients with LD flap reconstruction. You can notice can reconstruct in any quadrant of the breast. This is the lower inferior quadrant. This is the upper portion, and this is the supermedial quadrant. So extended LD flap is the modification of conventional LD flap. This is first tested by Hawking et al. And in this case, we will take additional tissue beyond the usual boundaries of the LD flap. It will take extra amount of the LD muscle. Can take up to the iliac crest actually, and in some cases we may take the serratus anterior muscle and the scapular fat pad also. So it allows a larger defect to be reconstructed. These are some of our cases. Here you can see the extra amount of muscle we take for a total mastectomy reconstruction. So mini LD flap is a modification of conventional LD flap, where a small part of the muscle is taken, and we may take we may take with or without skin flap also. And it can be done through the axillary. We don't have to put a separate back incision here. We can do it through the axillary incision itself. The advantage is the preservation of the muscle function. We don't take whole of the muscle, so we can preserve the muscle function, and there is a reduced donor side deformity and scarring. This is one of our patient after mini LD flap reconstruction. So the muscle sparing LD flap, here we don't take the muscle except a small sleeve of muscle around the descending part of thoracodorsal artery, and we raise the subcutaneous tissue flap for reconstruction. So here in one of our cases, after this is a case of recurrent fillers, so we did a total mastectomy with an implant with an LD flap coverage. So LD flap remains versatile and are suitable for a range of breast reconstruction, despite of advancement for other sophisticated flap techniques. It offers a cost-effective substitute for implant reconstruction in research poor countries. Now I invite Dr. Rajat yourself for free flap.
Very good afternoon, and I'll be talking on free flaps in breast reconstruction. I think Dr. Deva will be presenting before me. So I'll be covering the role of CT angiography in planning the breast reconstruction. So this work was done as a part of thesis, and our aim was to study the anatomic and vascular basis of DIEP, AIMAP, and TDAP flap perforators using vascular imaging, using CT scan as a tool. So our objective was to determine the precise location, course of the perforator, and the external diameter of all three perforators using CT angiography as a tool. So this was a prospective observation study. It was done in our institute from 2021 to 2023, and it was done using UCT angiography, as I told you, and 20 patients were recruited as a part of this who underwent routine preoperative planning as a part of staging in the preoperative time. We used 100 ml of contrast injected at 4 milliliter per second, and thin sections were taken from the root of neck to the lesser trochanter, so that we will cover all three perforators. And apart from this angiographic phase, which is the arterial phase, we also took portal venous phase, which is used for the routine staging purpose. So the first thing about the DIEP flap, this is how this is the anatomy of the DIEP flap. There are three types of DIEP flaps described. This is the type 1. Here there is no branching, there is a single dominant artery which is giving out perforators before anastomosing with joining with the superior epigastric artery. This is the second type wherein there are two branches giving out multiple perforators, and this is the type 3 which is giving out three branches. So this is the branching point. We were trying to find it out on CT angiography, and so this is about the types of branching pattern and the location of branching point. For example, here this is a branching point, and this branching point can vary, and it can be placed more caudal or cranial according to based on the patient. And we also looked at which of these branch, if there are 2 or 3 branches, which of this branch gave out the dominant perforator, whether the medial trunk gave out the dominant perforator or the lateral trunk gave out the dominant perforator. So we also looked at the features of the perforator, also the location or the origin of the perforator. We took both the x and y coordinates in relation to the umbilicus. Umbilicus was the reference point, and we also looked at the intramuscular length of the collateral or the perforator, the subfacial length, the length for which the subfacial part of perforator was seen, and we also looked at the point where it exited the rectus sheath, anterior rectus sheath, and we also looked at the total pedicle length right from the origin of deep intraepigastric artery. So these are few representative images. This is the DIP, deep inferior epigastric artery. This is a MEPT image showing the entire artery. This is a type 1 pattern because there is a single dominant tree here without any branches. And this is the dominant perforator which was arising from that deep intraepigastric artery. And this is an intramuscular course, and this is a subfacial course, and it exited the rectus sheath, anterectal sheath from this point, and which is better seen on the axial images. So based on this, we from this 20 patients, we found that type 1 branching pattern, which is a single dominant artery without any branches, is the most common type of pattern which we found. And the dominant perforators actually arised from the medial branch of the deep enteroepigastric artery. And the dominant perforator size of the dominant perforator was around 1.78 millimeters. We compare it with the existing literature. In Moon and Taylor et al. Found that type 2 pattern was the most common, whereas we found that type 1 is the most common. And there are other angiographic studies which found that one of the study found that type 2 is the most common, whereas the other study, which is the more recent one, found that type 1 is the most common, which matches with our findings. This is a scatter plot showing the branching point, which is at the origin of the DIP, the branching point, the origin of the perforator, and the exiting point of the perforator. So the branching point is roughly around 9 centimeters. If 0 is the point of umbilicus, you consider this as the point of umbilicus, and this is the x and y axis distance from the umbilicus. So we found that the branching point is at the level of around 9 centimeters from the umbilicus, whereas the origin of perforator was around 3 centimeters from the umbilicus, and the exiting of the anterior rectal sheath happened at around 1.5 in the x-axis and 3.5 in the y-axis. So even if we compare it with the literature, they are broadly very similar to our findings. So the length of the perforator was 4.27 millimeters, centimeters, plus or minus 2.4 centimeters. The length of intramuscular segment was 5.22, and the total pedicle length was around 16.5 centimeters based on our study. Coming to the IMAP anatomy, so it is the recipient artery if you are doing a free flap, or it can be used as a flap in oncoplasty also. The fourth intercostal IMAP can be used as a flap for oncoplasty. We looked at again 220 patients. So we looked at the initial top five intercostal spaces. So cumulatively we looked at 200 intercostal spaces, and we also looked for the dominant perforator on each side, which is the sample size around 40, because 5 in each side for 20 patients. So that comes to around comes to 40. And we also looked at the characteristics of IMAP at the fourth intercostal space. These are the parameters which we looked at for all the dominant perforators: diameter at the level of pectoral fascia when it pierces the pectoral fascia, location of this perforate at the site of perforation from the sternum, and the total length of the perforator right from the origin of the IMA. These were the things which we looked at, and this is again images. MIP image showing a dominant second intercostal space perforator, and this is another perforator which is arising from the IMA, crossing the intercostal space, exiting at this point. So we measured the entire length, which is a perforator length. We also measured the distance from the sternal lateral border of the sternum, and the intercostal space where it crossed, and the site of exiting of the artery through the pectoral fascia. So based on that, we found 66 perforators in a total of 200 intercostal space, which is around 1.6 perforators per site. And we found that the dominant perforator was mostly seen in the third intercostal space, followed by the second intercostal space, and which is roughly matching with the existing literature. This is the space-wise distribution, wherein we can clearly see that third intercostal space is the most common, closely followed by the second intercostal space. And the incidence of fourth intercostal space perforator was around 35%. If we compare it with the literature, the reported values are around 13%, but we found 35% of our patients had IMAP 4, And IMAP4 was the dominant perforator in 10% of those patients. Now to the TDAP flap, the thoracodorsal artery perforator is a branch of subscapular artery, which is a branch of axillary artery, which has two branches. One is a horizontal branch, one is a descending branch. We are interested in this descending branch of the thoracodorsal artery, which gives out perforators, which will cross the latissimus LD muscle and before entering the subcutaneous plane. So this is the, again, MIP image showing the anatomy of the LD artery, sorry, the thoracodorsal artery on a MIP image on a CT angiogram. This is the vertical branch or the descending branch of the artery, and whereas this is a horizontal branch. We are interested in this descending branch. And this is how on a CT angio the perforators are seen, and this is the perforator which is crossing that lateral dorsal muscle before entering the subcutaneous plane. And these are the parameters which we measured: the size of the perforator, the length of the perforator, and the total length of the pedicle, which we measured from the level of the apex of the axilla, and also the distance from the most anterior most part of the LD muscle and the exit of the perforator. So total of about 57 perforators were identified, and again the frequency of identification is 1.2 perforators per side was our detection rate in our patients. So concluding this DIP flaps, there is some variation in the anatomy in the population if you compare it with the existing literature, and which has its own implications in the safe harvest of the flap. Dominant IMAPs were found in our population in second and third intercostal space, and IMAP4 was present only in 1/3 of the population. Hence, there is a need of preoperative imaging to localize the IMAP4 perforator. Whereas TDAP perforators are reliable perforators with constant anatomy and which can be used for oncoplastic reconstruction of breast. Thank you so much. I think this will be followed by Dr. Raja Tiwari.
Good afternoon again. So I will begin by saying why free flaps for breast reconstruction. So free flaps because they provide a large amount of tissue and which is supplied by a single blood vessel. So sometimes we get rare indications when all these flaps have already been performed. This is the patient in which a LD flap was already performed and developed a recurrence. And then the salvage mastectomy had to be performed, exposing both the pericardium and the lungs. So in this case, it is obvious it requires a good cover with a reconstruction of the chest wall. And in these conditions, free tissue transfer is the best. As you can see, it provides not only the skin and soft tissue, but also a deep fascia of the thigh, which can easily cover the chest wall, any implant if it is placed. So this flap is basically an anterolateral thigh flap, and it is taken from the lateral side of the thigh, and it is based on the lateral circumflex femoral vessels. And the pedicle, you can see, this is the lateral circumflex femoral vessels, which is a branch of the femoral artery, and it gives a small perforator. To be again very clear, perforator is basically a tertiary branch from the artery and the vein. So it can either pierce muscle or a septum, and then it supplies the overlying skin after piercing the deep fascia. And once the flap is inset in the recipient side, we perform arteriovenous anastomosis by joining the arteries of the flap to the arteries in the nearby region. So this is the same patient after 6 months. Now, apart from that, like Dr. Sinu mentioned, the aesthetic form reconstruction is very important. So yeah, you can see in the image that the total mastectomy, skin sparing mastectomy was performed, but the breast was now reconstructed. And the patient definitely had a great psychological impact when the form is not reconstructed. So in these situations, the easiest options are performing a pedicle flap, but again, in most of these cases, enough tissue after a total mastectomy may not be replaced, and this can be evident from the images. And if we are adding an implant along with the pedicle flap, there can still be sometimes problems with the implants with the radiation. So these implants can get exposed, and on all these situations, an alloplastic reconstruction can provide a homogeneous and very well aesthetic outcome. So the two most common flaps that we perform in practice, like Dr. Deva mentioned, the deep inferior epigastric artery perforator flaps, which is from the lower abdomen, and the profunda artery femoris flap or the pap flap from the medial side of the thighs. So which flap is to be taken depends on certain criteria. So mostly the medial thigh flap or pap flap provides small amounts of tissue. So this flap is best suited in women who have small breasts or we are doing a unilateral reconstruction. Similarly, there are patients who do not want any flap to be taken from the abdomen or there's hardly any tissue available in the abdomen. So in these situations, a pap flap is done. So pap flap is basically based on the profunda femoris vessels, and these vessels usually emerge from the adductor magnus muscle. And like you can see in the last figure, this is at the profunda femoris vessel perforator. It is supplying only the skin and the subcutaneous tissue, no muscle and no other structure. So there is hardly any donor site morbidity, and the donor site is scar is very well conceived. The profunda femoris artery is basically arises from the lateral aspect of the femoral artery. It travels in the posterior compartment of the thigh, and it gives multiple perforating branches. The most proximal perforator is the largest one, which emerges through the adductor magnus muscle. This is the surface marking of the artery. So the perforator is frequently found 8 centimeter distal to the groin crease and around 2 centimeter posterior to the posterior border of the gracilis muscle. Then for this also we use two methods to identify the perforators. The first one, easier one, is the handheld Doppler, but in obese patients it becomes very difficult to identify the impulse with a handheld Doppler, and in these cases a CT angiogram may be performed. This is the positioning for surgery. So a simultaneous harvest of the flap along with the tumor resection can be performed, and for bilateral cases also a bilateral frog-leg position can be done to harvest two flaps. This is the flap after the harvest. So you can see that the flap has been harvested completely based on the profunda femoris vessels, and a sensory nerve is also taken if found to make the breast sensate. This is the size of the normal perforator. It is usually less than 1 millimeter. And these are some of the case examples which have been reconstructed with the pap flap, and you can see that good volume replacement and symmetry has been achieved. Now the second flap is the DF flap, and this is mostly required for women who have relatively large reconstruction of breast mound in excess of 500 grams, or there is bilateral breast reconstruction is needed. So in these cases, because DF flap is one flap and we can divide it and make it two flaps out of one. So DF flap, the anatomy has already been discussed with Dr. Deva. So it is based on the perforators from the deep inferior epigastric vessels, and this flap is taken from the lower abdomen. And the donor site is primarily closed. The new umbilicus is recreated. So this is just a scar, and there's no donor site problems. And then the flap is taken to the chest, and the anastomosis is done between the internal membrane or thoracodorsal vessels and the recipient vessels of the deep inferior epigastric system. So this is the anatomy. These are the deep inferior epigastric vessels. So for the flap harvest, we identify the perforator medially, and we start retracting the muscles, fibers medially and laterally, and then continue the dissection until we reach all the way up to the femoral artery where this vessel is divided. And like said, we always have to identify the dominant perforators conducting a CT angiogram. This is after the dissection is complete, and you can see the one flap is divided in the center to make two flaps, and these are the two vessels on either side which have been dissected all the way up to the femoral arteries. This is a representative case, a 26-year-old unmarried female, and she had a BMI of 28, but her height was 5'11". The breast tissues were in excess of 1.5 kg. The excised specimen measured 1,120 grams. A skin sparing mastectomy was performed. And in this case, apart from just supplying the tissue, we also have to contour the tissue. So when large volume reconstruction have to be performed, the breast mount has to be contoured. So in this case, we folded the flap and did the anastomosis of one flap to the distal end of the other artery. This is the final mount which has been created, and the same has been put under the skin in the recipient area, and an anastomosis has performed from the thoracodorsal vessels. This is the same patient with volume replacement of 1,030 grams. These are her post-operative images, and you can see the good volume replacement and contouring has been obtained in the same patient. The other methods, like has already been mentioned, include the contralateral symmetrization procedures and secondary lipofilling. Apart from this, when the nipple and annula is also sacrificed, it is usually reconstructed, and we mostly use a technique called the skate flap. So in this, the radial along with the inferior advancement is taken, and this thing is folded to create the nipple, and then the entire thing is resurfaced with split skin graft. So split skin graft, in time, it hyperpigments and gives the appearance of an areola. Alternatively, tattooing can also be employed, 3D tattooing, to create a nipple and areola. So finally, to conclude, modern breast reconstruction techniques offer many options for a three-dimensional reconstruction of breast, and the breast reconstruction is gradually changing from just reconstruction to breast graft. Thank you so much. And now Brijesh will come to discuss about implant-based reconstruction.
Good afternoon, everyone. Thank you, sir. Now I'm going to discuss about the implant-based reconstruction, which is the another modality of the breast reconstruction. What is the breast implant? Breast implant is the fluid or gel-filled device used for the breast reconstruction. Basically, it used for post-mastectomy reconstruction in breast cancer, breast augmentation, congenital defect and deformity of the chest wall, and gender reformation surgery. Globally, implant-based reconstruction increases 11% annually, and Western country implant outnumbered autologous reconstruction because autologous reconstruction has longer operative time, and for implant-based reconstruction, cultural shift toward the acceptance of implant, funding available for the reconstruction, and less surgical risk at the operative side, donor side. First, implant described by the Cronin and Brew, which is thick, smooth wall filled with a viscous saline gel and affixed to the implant pocket to prevent the rotation. Over the period of time, implant developed and modified according to the requirement. And now we currently use 5th generation of the implant, which are more cohesive, semi-solid gel, less chance of bleed, and low incidence rate of contaction. Basically, implant-based reconstruction suitable for the younger patient, non-smoker with no other comorbidities, good quality skin with subcutaneous fat thickness of more than 1 centimeter, small to moderate side of breast with no previous history of radiation therapy, and patient realistic to expectation. There are few absolute contraindication which include previous radiation therapy, current smoker or respiratory distress diseases, unstable circulation in skin envelope, and opposite ptotic or large breast that the patient wishes to preserve and match. Implant-based reconstruction can be two types. First is the one stage in which we place the permanent implant in single stage, and second is a two-stage procedure in which we place the tissue expander in the pockets, which increase the size of the skin flap and the soft tissue to be replaced by permanent implant after the in the second surgery. On the basis of implant location, the implant can be categorized in the prepectoral or subpectoral implant. Prepectoral implant can be performed with the alloplastic adjoint, which can help in the implant-based reconstruction in prepectoral reconstruction. These are some alloplastic adjoint like a cellular dermal matrix, xenograft, allograft. Like other surgery, the implant-based reconstruction have some complication, like early complication which include hematoma, infection, and skin flap necrosis. In late complication include asymmetry of the breast, wrinkling, and malposition and capsular contracture mostly. On the basis of some current study, the short outcome of the implant-based reconstruction include implant loss in 9% of cases, hospital readmission in 18% of the cases, deoperation within 3 months in 18% of the cases, and the chances of infection in 25% of the cases. In a long-term outcome, the currently published literature shows that the aesthetic spore and capsular contracture rates are remain stable, and irradiated breast have high rates of the capsular contracture, which improve over the time. Here, this is some our experience in first this case. This is the 18-year-old young female patient which presented with a large phalloid tumor, which where we did mastectomy followed by implant-based reconstruction with help of the LD flap. This is the final outcome. This is the another case where we perform skin sparing mastectomy, and we place a tissue expander, and in second we will do a second stage operation after the completion of chemotherapy and radiotherapy. This is the short video of where we placing the expander and inflated with the sunlight. This is the final picture of tissue expander after placing the tissue expander. Now coming to the another armamentarium of the breast reconstruction, this is known as the lipomodeling or free fat transfer. Free fat transfer is autologous, also known as lipofilling. It is a minimally invasive technique that uses the patient's own fat to correct the disfiguring swiftly after the breast surgery. And most common site for the fat transfer is the abdominal wall or thigh. For breast transfer, fat transfers, autologous fat transfer surgery mainly indicated in the for the correction of the post breast conservation surgery defect, correction of the breast asymmetry, breast augmentation, and volume enhancement in the flap reconstructed breast. These are the it can be done in 3 steps. First is the fat harvesting, then centrifugation, and fat is the fat injection. Here I am demonstrating the steps with the help of video. In first step, we infiltrate the tumescent solution around the donor side. After the help of cannula, we spread the fat. After the fat aspiration, we do the centrifugation of the fat with the help of machine, which roaming around 300 rpm for 3 minutes. After the centrifugation, the fat is distributed in 3 layers. Upper layer is broken adipocyte triglyceride, which get discarded, and lower layer also get which include blood and cellular debris, which also get discarded. Middle layer used for the autologous fat transfer. In fat injection, firstly we give a small incision. With after the small incision, we with the help of the sharp cutting cannula, we cut the fibrous band. After that, we injecting the fat in the from the deeper to superficial layer in a fat fanning style. This is the video where we infiltrating the tumescent with the help of With the help of the cannula and 10 ml syringe, we spread the fat. Here means after the giving small incision, we cut the fibrous band of the tissue under the flap. After that, so this is the our experience assessment of the outcome. This is the our experience. Patient who undergoing fat transfer, on the basis of patient satisfaction outcome, out of 7 patient, 1 patient so highly satisfied and 4 patient are satisfied. On the basis of surgeon, on the surgeon are giving the excellent in 1% 1 cases, and in 1 patient case give 1 patient, and cosmetic outcome good in next 1 patient. This is the 1 patient who gone breast conservation surgery. After that, sequential fat transferring, autologous fat transfer with, and the finally the outcome was after the implant. This is the final outcome with help of implant. So free fat transfer is a simple and safe reproducible technique, can be used in adjunct to the other angioplastic technique, and it gives final perfecting procedure, and it gives a better cosmetic result, produce a better psychological outcome. I invite you, Krishna sir, for
Good afternoon, everybody. So I'll be describing our experience over the last 5 years. So before we go into the number of cases that we have done over the last 5 years, in collaboration with Dr. Deva, we did the cadaveric part of the study where we studied the anatomy, the anatomical basis of the different perforators. As you see that most of these reconstruction techniques are based on some type of perforator. So we did the cadaver dissection on 12 fresh heel cadavers, and we studied the DIP, IMAP, the LICAP, the TDAP, and the ICAP flaps. So these are the pictures showing the different type of perforators and the major arteries that we dissected in the cadavers. The DIP flaps, then this is the internal mammary artery perforators and its perforators, and the thoracodorsal artery perforator flaps. So what we found that the location, the size, the length, and the force of these perforators as studied in cadavers were all in concordance with that of the CT angiographic findings. The only difference was that the size and length was slightly shorter in the cadaver, mainly because there is no blood in these vessels, and also there is no lack of muscle tone. So over the last 5 years, we have almost operated around 500 cases with patients with breast tumors, out of which 92 patients underwent breast conservation surgery. Thus, the overall breast conservation rate was around 19%, and this increased to around 35% in patients who had early breast cancers. You can see with the slide that the number of breast conservation that we have been performing in a unit has gradually increased over the period of time, where it started to around 5% in 2019, and now we are almost close to 40% in the present year. So majority of the patients, they had early breast cancers. 17% patients included locally advanced breast cancers. Important point is that about 66 patients underwent upfront surgery, and there were 26 patients who underwent the breast conservation post neoadjuvant chemotherapy. Now, the 51 patients who underwent breast reconstructive procedure, 38 were post BCS, 12 patients required total breast reconstruction post mastectomy, and 1 patient underwent a bilateral reduction mammoplasty for gigantomastia. Now, the 38 patients who underwent reconstruction post BCS, majority of them were rotational or pedicle flap like the ICAP, LICAP, IMAP, or TDAP flap. And the remaining 13 patients underwent level 1 oncoplasty with volume displacement techniques as has already been described. So as you can see from this slide, light cap flap was the major reconstruction technique which was used for partial breast reconstruction, followed by the LD flap in 10 patients. Total 11 patients underwent a total breast reconstruction. The most common technique that was used was a mastectomy and an LD flap. We had an LD flap with an implant in one patient. 2 patients underwent a DIP flap, and 2 patients underwent a flap, where we had a collaboration with Dr. Raja Tiwari. 1 patient underwent a bilateral nipple sparing mastectomy with a tissue expander. So as you can see, if we summarize the overall reconstructive procedure that we have used over the last 5 years, LD flap still continues to be the workhorse of all the flaps, accounting for almost 30.8% of the reconstructions, followed by the LICA flaps. Now, out of the 51 patients who underwent the partial or total breast reconstruction, 37 patients had carcinoma breast, and the remaining have the phyllodes tumor. In phylloid, all the patients with phyllodes tumor underwent some form of LD flap reconstruction, and 1 patient had an implant placement along with an LD flap. Coming to the outcomes of these patients, the overall morbidity in our over the last 5 years been around 16%. But the point to see is that majority of these morbidities have been clavined into one, not requiring any intervention. The most common morbidity was seroma and surgical site infection. We had 1 patient who had a local recurrence, and there were 2 patients who had partial flap necrosis, but we were able to salvage the flap by doing a gradual debridement. We also did a cosmetic assessment by the surgeon and nurse using a scoring chart, and we also studied the patient satisfaction based upon a questionnaire which included the satisfaction, comfort with bra, social life, and sexual life. As you can see, that majority of the patient has showed good results in terms of objective cosmetic outcome as well as patient satisfaction assessment. Thus, to summarize, our overall breast conservation rate has been around 19%, and it increases to about 35% when it comes to early breast cancer, and has been improving over the year with the present BCS rate of around 35%. As you can see that these numbers are much higher than the national average of about 5.6%, which Dr. Sinu has shown in the beginning slides, but we are still lagging behind high resource countries. Similarly, though our post-mastectomy detection rates are low, but they're still higher than the national average, and we are much lagging far behind the Western countries. But this may be because of the psychosocial factors, and also because we are working in a very resource-limited settings. But these patients all have good cosmetic outcome, and there has been a good patient satisfaction in all these patients over the last 5 years. Now, I'd like to invite Dr. Sinu to kindly talk about the advances and to take home message. Thank you.
It's extremely important that when you're following one particular field of surgery, not only to do what is state of art, but also look at what is there in the future. Now, what is there in the future for people who are interested in breast surgery? One is advances in surgical techniques, the other is in the advances in the surgical adjuncts. Now, the advances, like in any other field of surgery, it is the robotic surgery. The application is in robotic skin nipple sparing mastectomy and harvesting of robotic free flaps. Why is that? Because this provides high precision, there is greater flexibility and better control. So this is one of the patients in our wet lab where we attempted to do the robotic nipple skin sparing mastectomy. The trocars are placed same as you do through a submammary crease incision, and then in this video play. Okay. So basically, all of you, I request you to visit the wet lab, use the robot which is there to practice surgery. So we had to dock the robot because this is the first time we were doing, we had some difficulty. And as you can see here, it is quite easy to raise the flap, the breast tissue over the pectoralis major muscle. Similarly, Dr. Raja Tiwari, like I encouraged him, and he was like very enthusiastic to come forward and harvest the DIP flap using the robot, and he feels that the type of tissue he got and the length of the artery is much better as he gets when he uses it when he does an open surgery. So there are some advances in the lumpectomy technique. One is the increasing imaging and localization. As you know that all of us now can routinely use ultrasound, but increasingly you can use 3D mammography in more precise localization. Especially in impalpable tumors, this is all the more important because it leads to more accurate and adequate excisions. The other very interesting which is coming in literature is the use of a probe on the margin to see whether the margin is positive or not. This is again especially important if there is impalpable tumor and if there is microcalcification, because it reduces the re-excision rates and improves the local recurrence rates. 3D imaging and printing again coming up a very big way as in rest of the fields of reconstructive surgery, especially in maxillofacial surgery. 3D imaging helps you in preoperative planning and it also helps you in patient education. Like if you have a good 3D imaging, you can tell the patient what the patient can expect and can show the type of the result the patient gets. Similarly, 3D printing, it is literally possible to reprint the whole breast which you are implanting and show the patient, and also the surgeon can practice multiple times on it before going on and operating in the real patient. So it's quite exciting field actually. So the take home message for all of you is that currently in all patients who are eligible for conservation, breast conservation surgery is the standard of care. And what we have found is that, like as Krishna has shown, initially we used to do only breast conservation. We tried to mobilize the tissue close, so we were not very satisfied with the result. But with increasing use of the local perforator flaps like the ICAP and LICAP flap, our breast conservation surgery rates have increased dramatically. And all patients who undergo mastectomy, they should be counseled and they should be made aware that it is possible to do a breast reconstruction either in the same setting, which is the best, which is primary reconstruction, or at a later stage. And if there are minor deficits, though free fat transfer has been used to create the whole breast, but as it stands today, at least in our setting, I feel that if there are minor defects which need a touch-up, then free fat graft is a very good method which can be called as lipomodeling. So thank you very much, ladies and gentlemen. If anybody wants to have any comments, you are welcome. Dr. Bansan? Anita, you want to add something?
My concern remains long-term follow-up with surgery when filling or tissue transfer. What is really my concern? What happens to these patients when we see them in follow-up? That is my concern. 5 years, 10 years down the line. The things that sometimes they do in mere surgery. So I hope as we are progressing with the flaps and all, the texture that is coming up, the big wave, is more important than the texture.
Yeah, I think it's absolutely right. What Anita is telling is about the cases in which we had done level 1 oncoplasty by doing volume displacement, and some of these tissues have become rock hard, especially after irradiation. So again, very important is the principles. Whenever you are raising for volume displacement, always raise in a single plane as far as possible. If you raise both subcutaneously as well as from the pectoral fascia, then the vascularity gets compromised, and added to it, radiotherapy will cause radiation-induced fibrosis and it can be a problem. So again, attention to detail and following the principles of the technique of surgery, you can improve your results. And especially after using the LICAP and ICAP flaps and with modifications in the radiotherapy, results are much better now. Yes, Sohan? Absolutely.
The patient has already been so will DIP still be
Yeah, so only the local tissues are affected by radiation. So all the deeper tissues are still The local issues sometimes become most cases will be able to replace all the issues. That's why the system is not controllable.
And to cover
Lateral defects are really important. Never affects. We also from the screening of coming down very
I think very pertinent question. Basically, see, in such cases, I think you should resort to CT angio to see that the vessels are patent. And as you have seen that, like once you go deeper, usually the blood vessels are not that much affected. So though there may be a lot of fibrosis. Yeah. So yes, Deva, can you tell us anything like what is the effect of radiation on blood vessels? Like you seeing them, no? The blood vessels.
But you don't know that how pliable and the texture of the, but it is better. Again, in lung you get fibrosis. Here, the vessel is patent, but there will be some fracture in the circulatory system. That will get standard, maybe because of fibrosis. The vessel itself is patent.
Both the DIPs and TAP we did with post radiation.
Hmm? Yeah, post radiation. They are more and smoking.
The diabetes also you get plaques, so that plaque in the media becomes horrible. And mostly that is an intraoperative procedure.
Any questions from residents and others? So if there are none, thank you very much for having come.